Denise, do you think that the incidence of acanthamoeba infections are increasing?
Yes, the incidence, the prevalence is increasing, and also the cases are becoming much more virulent. So there was a meeting, an FDA meeting 2 or 3 years ago with experts in acanthamoeba, and everybody agrees that there is an increase in prevalence and in severe cases.
Do you think that contact lens use is still the most important risk factor for these infections?
Yes, unfortunately, almost 90% of the cases are related to contact lens wear. And now we have something new in relation to scleral contact lens. So patients are getting acanthamoeba keratitis wearing scleral contact lens because the lens is larger. It's very difficult to do friction in those lenses. We do believe that this reservoir of saline solution can predispose to the infection. And also the plunger that we use to put and to take the contact lens, the scleral contact lens, can also become contaminated with acanthamoeba. So contact lens is always a risk, always.
Do you have cases in patients that do not wear contact lenses?
Yes, I do have. They are very rare, but I do have a patient who went to a place that the water came from a tank, was a place for vacation, and then during the exposure to swimming pools and all those things, he got a acanthamoeba infection. So it is possible. It's very rare, but it is possible to get.
Would you make a comment on combined
Drugs.
drugs?
Yes, there was a very nice discussion about this. We do use 2 kinds of drugs to treat acanthamoeba, but the second one, that it is a diamide, it is not approved in the majority of countries. So in my opinion, using 2 drugs, it's better because it enhances the treatment, but monotherapy with a biguanide, it's also causes an efficacy, but if you combine 2 drugs, at least in the beginning of the treatment, you can get better results in the long term. So I do believe you should treat with 2 drugs. And you can, as we were discussing in this meeting, you can cycle the drugs trying to get rid of the parasite. So this is something new that we can try in very difficult cases.
Would you tell us important clinical findings that tell us that the disease is getting worse or is a very aggressive clinical situation?
This is a very important question. What we see, we start treating a patient and there is, a division. The patient can get worse because we are not controlling the parasite, or the patient can get worse because there is lots of toxicity. The drugs cause lots of toxicity. So you have to figure out the signs of worsening of the infection and signs of worsening due to the toxicity. So if you cannot do this, because sometimes you cannot be sure that it is infection, you just stop the medication for 1, 2, or even 1 week. Acanthamoeba is different from Pseudomonas, for instance. Nothing's going to happen in 1 week if you stop the medication. And of course, if the patient gets better, it was a toxicity. If the patient becomes the same, probably it is an infection. So this is a nice tip to differentiate toxicity and infection.
When to use steroids?
Oh gosh.
Acanthamoeba.
This is very difficult because steroids, they make the acanthamoeba to be more virulent. Otherwise, on the other hand, steroids can control inflammation. So if you treat a patient, you can start corticosteroids, but never, ever strong corticosteroids. I would suggest mild corticosteroids, in the most frequent, like 4 times a day. Do not use strong corticosteroids with acanthamoeba. It is a risk.
Scleritis in acanthamoeba, is this an immunological disease or this is an infectious disease?
Another good question. There is a paper showing some parasites in the sclera, but the whole world agrees that it is immunological disease. And scleritis is a sign of bad prognosis in acanthamoeba keratitis. So if you have a patient with scleritis and corneal infection, you should be really treating carefully this patient. But I do believe it is immune reaction.
When you see this immune reaction, do you give them oral steroids or topical steroids?
Well, some very good ophthalmologists, they give even immunosuppression for those patients because sometimes this scleritis is so severe that you can put in risk the eye. So I don't like to treat with immunosuppression because acanthamoeba stays in the eye when the patient is immunocompetent. I'm always afraid to give immunosuppression. But anyhow, if the case is very severe, yes, I give oral corticosteroids.
What the pupil can tell us in an infectious disease such as acanthamoeba keratitis?
We don't know why some patients develop a very nasty syndrome, if I can use this word. While treating acanthamoeba patient, the eye starts developing mydriasis, and when we see this, the patient will probably evolve to a intumescent cataract and also glaucoma. So those patients, we have a very high risk to lose the eye because of glaucoma. So as soon as during the treatment you see that the pupil is getting enlarged, you should do something. And do something means probably a penetrating keratoplasty, taking the lens out, implanting an intraocular lens, and closing the pupil, surgically speaking, doing an iridoplasty to keep the pupil very small. Otherwise, during the post-operative time, the patient will keep enlarging the pupil and will go to a glaucoma. So it's very important to be paying attention to the pupil size.
How do you educate your patients to avoid this disease?
Oh, that's so important. It's such a difficult infection. So we should tell them to be careful with the time that you use contact lens. You have to dispose of the contact lens following the rules of that particular contact lens. You should do friction. Although some products, they say there is no need for friction. For acanthamoeba, yes, there is a need for friction. Perhaps for bacteria, you don't need to do friction. Also, you have to always put fresh multipurpose solution. You cannot complete the old one, or you cannot use any kind of solution like saline solution. It not substitute the multipurpose. And you cannot, take a shower with the contact lens. You cannot wear contact lens swimming. If you want to swim with contact lens, you should wear a disposable daily contact lens. And even in this way, you can get acanthamoeba. So the risk will be a little bit decreased, but you do have to use a disposable or not, daily disposable, or not use any contact lens at all when you go to a swimming pool.
Thank you, Denise.
Thank you, Mauro.